From Northwest Eye Surgeons and Sight Partners, I am Dr. Brett Bentz, and you're listening to The Focal Point, where we invite doctors and surgeons from the fields of ophthalmology and optometry to discuss the latest trends in medical eye care. This is the final podcast for our first series of podcasts that has been designed as a mix of mainstream and relevant clinical topics that we hope has been refreshing to you to review with us. For today, we are going to discuss perhaps one of the leading hot topics that we hear about, and certainly heavily marketed, which is refractive lens exchange, or RLE. Now, RLE has been around for many years, but recently it's been a bit of a resurgence, in part due to improvements in IOL optics and technology, but more on that later. So to discuss this further, we are very fortunate to have one of our leading surgeons and true patient advocate for making the right decision for them, Dr. Christy Bailey. Dr. Bailey practices at our Bellingham Whatcom Eye Surgeons Clinic and also at the Northwest Eye Surgeons Mount Vernon office. And she specializes in cataract surgery with premium IOLs that fall under our vision correction plans. And she also manages medical retina patients. As a side note, we want to acknowledge that she has a leadership role with us as managing partner of Northwest Eye Surgeons and Sight Partners. So that's a big hat. So Dr. Bailey, thanks for joining us.
Well, thanks so much, Brett, and thank you for that wonderful, glowing introduction that makes me stand really tall. So I really appreciate all that, and really happy to be a part of this. I think this series has been a great kickoff for increasing knowledge and education and connection between our practice and all of our referring doctors, and hopefully anybody else who's listening. I think the more we know, and the better we do. So I'm delighted to be a part of it.
Okay. So to start off, we are in the primary eye care optometric physician office, and their patients ask about RLE and if they would be a good candidate, especially after hearing about it from friends and TV and radio ads. So what is your recommendation to them? Who is a typical good candidate?
Yeah, absolutely. And, as you said, this is refractive lens exchange is becoming more and more popular. As you know, it's been around a long time. But with more, advertising and discussion and the increase in the number and quality of our premium IOLs, it's becoming a greater proportion of the patients who are seeking to have spectacle independence. So the first thing we'd be looking at is those with high refractive errors, the myopes, hyperopes, patients with high levels of astigmatism that are obviously out of the range of corneal refractive surgery. Those are the more obvious patients. Or patients whose refractive errors may be just within the margins of corneal refractive surgery, but whose quality of vision could be compromised by that level of corneal treatment that would be required. And then finally, any patient who is at or nearing, the age of dysfunctional lens syndrome, where presbyopia will be coming into play in short order. Those are really great candidates for this. So, the low-hanging fruit patients who would be an ideal candidate would be perhaps a hyperope who is nearing or in presbyopia age. Those are ideal candidates. But again, high astigmatism, high myopes, also great candidates as well.
At the same time, can you think of some qualities of somebody who would make them a poor candidate for RLE?
Oh, absolutely. Absolutely. So, as with any, refractive procedure where the patient, has, expectations of spectacle independence and good quality of vision, we want a generally healthy eye. So, as with any refractive procedure, the ocular surface really should be optimized. A poor tear film would be a poor candidate for either a corneal or a lens-based procedure. That's certainly something that could be treated and optimized, but we'd want to look at that carefully. Any other comorbidities, such as iritis, recurrent iritis, uncontrolled glaucoma, uncontrolled diabetes, or other retinal disorders such as AMD. These also make poor candidates not only for complications and issues with the procedure, but also in expectations. Some of those things may not be absolutes. A person who has a high refractive error, they have mild AMD, and they really would like to have spectacle independence. That can still be accomplished. It's just there needs to be a much more extended conversation about expectations of visual outcome and what that can mean for them going forward. Same thing if you look at any corneal-based disorders such as Guttata, Fuchs dystrophy, those things. Anything that would make you hesitant about touching the eye to begin with should give you pause about offering a refractive lens exchange.
Many ads talk about this 5 to 10 minute painless procedure, and they perhaps oversimplify that this is a surgery. So if patients themselves ask about RLE, what would be a responsible answer about risks?
Absolutely. These are wonderful procedures. In general, these are very short surgeries. They're relatively comfortable to undergo. The healing process is fairly quick and easy, but this is still surgery. And so we should always take that seriously with both the patient and in the planning for all procedures in general. Some of the risks that we think about for a refractive lens exchange, frankly, they're the exact same as for cataract surgery. So, this is an intraocular surgery, so it does carry the risks of endophthalmitis, which, as we know, is extraordinarily rare. Retinal detachment is a risk as well. And that the difference is those particular risks are not meaningful risks when you're looking at corneal refractive procedures. So it is a bit of a different conversation. But the overall risks of cataract surgery, as we know, are pretty minor. And so, RLE would carry those same exact risks. And so the conversation should be the same. Particular attention should be paid to, a high myope who, by definition would have, a higher risk of a retinal detachment. So, the advantages of the surgery should very much be balanced against those risks, and a careful examination of the retina, and potentially even, as we would for even cataract surgery, if a patient is of cataract age and has a visually significant cataract, looking potentially at the peripheral retina, if there's an indication for potentially some laser to tamponade the retina and hopefully avoid complication, that should be considered an RLE. Of course, there's some advantages too here, surgically, because, one, this is a cataract preventing procedure, if you will. And so this will be, potentially the only surgery the patient will ever need. So that's an advantage there. And, also, a patient who does have a corneal refractive procedure and then goes on to having a cataract procedure later, they're also, introducing, potentially refractive surprise. So that could then necessitate touch-ups and additional surgery. So, there's pros and cons, but I think the responsible answer is to give the same risks as a cataract surgery would give.
How does age factor into the decision in your practice regarding consideration of RLE, especially considering the presbyopic population increasing in the demographic that we face as patients?
Oh, absolutely. As we see just with, cataract surgery patients, we're seeing, younger and younger patients coming in for cataract evaluations. And I think that's multifaceted. One, we are offering cataract surgery, sooner than we used to. Remember the time when we used to describe a cataract as being ripe, mm-hmm. and we would, the patient had to get to a place of, extreme visual impairment before the surgery would be offered. And now with the surgery becoming safer and the technology advancing, we are seeing younger patients having their cataract surgery done. So we're in addition to that, seeing younger patients coming in for RLE. So, in my opinion, once a patient is close to or at dysfunctional lens syndrome age, and they're starting to experience any of that, really the advantage is to move towards refractive lens exchange rather than corneal refractive procedure. So, I would say on average 40 or above, we really should be looking at that because they're close to presbyopic age. It won't be long before they're going to be needing a lens-based surgery regardless. So if that can be done and alleviate both the development of a cataract and also give them the offerings of presbyopic correction simultaneously, that's really the best option for the patient. I do take caution in a particular group of patients, such as the low myopes, your -2, -250s who still have, a great near range because, they still have some great near vision and a range of vision. And, the presbyopic, presbyopia correcting lenses that we have, while they're marvelous and have really just improved leaps and bounds in the last few years, they still do carry, some risks of, glare and halos and some night quality vision issues. So again, it just needs to be a very detailed and extended discussion with the patient about their goals and an understanding of that. Just make sure the patient is fully informed and has realistic expectations.
Thank you for bringing up the low myope topic, because a patient that we saw, actually when Dr. Steve Brown was doing surgery, it was a young woman, I should say young woman, she was younger than me. She was in her 50s who actually had surgery in a plano distance, but she was a -2.5, and she was extremely unhappy that she lost that myopia. So, patient expectations have to be explained, that what we think is a good outcome has to be defined by that person. So.
Absolutely.
So one last question, based on kind of your clinical judgment, so many multifocal IOL options. And so the question to you is, when it's going to be a multifocal IOL or extended depth of focus IOL or a hybrid, perhaps of both in each eye, what's your personal preference for RLE patients, and how do you base that decision on what factors?
So, and as we've seen, there's just an explosion of technology in the last couple of decades in terms of toric lenses, extended depth of focus lenses, different multifocals, the LAL now being available. So it really is an absolute plethora of options to choose from. In my personal experience, what I choose as my multifocal is the PanOptix lens. I have, certainly used a number of lenses over the years. All have had their pluses and minuses. And I really feel like my patients, since I started switching to the PanOptix several years ago, have been by far the happiest. The vision is more consistent in terms of achieving the distance, mid-range, and near. It does deliver in all those ranges without dead zones. I find that it does have less complaints of glare and halos than the previous generations by far, and better overall quality of vision. So, when looking at the most spectacle independence with having balanced vision in both eyes, that's the lens I choose. So for my patients who are really looking for achieving both distance and near, that's usually what I start with to see if they're a candidate for that. For my patients who are perhaps more light sensitive, they have activities where any glare and halo might be a problem for them. Then I look towards more of the extended depth of focus lenses. The Vivity lens I have found delivers excellent quality in this department. So distance and mid-range vision is quite good. I do find about a 50-50 result on my near, depending upon, how long the patient's arms are, right? And so I always caution the patient to expect that they still will need reading glasses, but at their distance, at their dashboard range, at their computer range, as long as it's a desktop, of course, it should be absolutely fine. And going back to the PanOptix, I also do still make sure that my multifocal patients know that in certain lighting and certain small micro near tasks, they may still need a light pair of cheaters for those things. We want to always set realistic expectations. Coming back to the extended depth of focus, one way that I find that, so let's say the patient is not a good candidate for a PanOptix, but they still want, more range than just distance and a desktop computer. A slight mini mono approach with an extended depth of focus lens can work really well. So setting the dominant eye for plano, of course, and then the non-dominant eye for a -0.5 or a -0.75. That can work quite well to achieve that goal. But I always want to make sure that a patient will tolerate that mini monovision. So I've learned over the years, to bring the patient back in and do trial framing. It's show them what it would be like to have the two eyes be even slightly different from one another. Certainly, we do this with a true monovision patient. We want to make sure we get the range right. But that can be really, really helpful in determining what range they should have. And then the LAL, I really am starting to bring this into my practice more and more because, the advantage of being able to alter the prescription after the fact to meet the patient's needs, that's just splendid. It's just a wonderful option to have. So certainly for my patients who've had any other previous corneal refractive procedure where we know that refractive surprise is a possibility, this is my go-to. This is what I do highly recommend for them for that reason.
You touched on a point a little while ago about patients who have had previous corneal refractive surgery, and we have to watch those patients, and they're a good patient for, as you mentioned, LAL, other forms of vision correction. What comes to mind is sometimes we see higher order aberrations in those patients, so we have to keep that in mind for patient selection for these multifocals. And Dr. Bannett, who I had a chance to work with and enjoyed working with him, he was always looking for that because of his corneal background. So we had to make some lens selections based a little bit on that risk.
Oh, 100%. You have to take that into consideration that if the cornea has been altered and you have a lens that's also going to create an aberration, those two coupled together, could give the patient, quality of vision that is not satisfactory for them. So you really do need to look at. So I'm highly cautious of doing a multifocal in a patient who's had previous corneal refractive surgery. Certainly have done it and have had patients be very, very happy with that. But again, it's a lot of counseling, and that may be a place where the Vivity or the LAL is a better fit.
Well, again, we thank Dr. Bailey for providing her perspective regarding RLE and giving us more information that doctors of optometry can consider when counseling your patients. Finally, we thank our incredible professional relations and marketing team for their work behind the scenes regarding the podcast and other marketing programs. We couldn't do this without them. So thanks to Stacy, Stephanie, Gina, Fernando, and Ken. That's this week's edition of The Focal Point. If you enjoyed today's podcast, please subscribe and tune in next week for another episode and update on medical eye care. I'm your host, Dr. Brett Bentz, and thank you for joining us.